Bismillahirrahmanirrahim. So today we have gathered to have some discussion on the early post-transrenal complications. So there is no surgery without complications. So complications are bound to happen. We divide these complications into medical and surgical. So today we will discuss few of the surgical complications that we come across usually in our early post-operative period. Yes, doctor.
Assalamu alaikum. I'm Dr. Mariam. Today we are going to discuss, as Dr. Suman already told us, about the early post-renal transplant management and the complications. So there are a number of the surgical complications that we can encounter in the post-operative period and which can predispose the recipient to a significant risk of the mortality and the morbidity. And these surgical complications are further divided into the some of the vascular complications and other ones are the urological complications. The urological complications including the urinary leak, lymphocyte, whereas the vascular complications including the arterial thrombosis, venous thrombosis, bleeding or hematoma. So, urinary leakage is the most common early post-operative urological complication that the recipient can encounter, with incidence of 0 to 9.3% of the cases. And the leaks typically manifest within the few days after the transplantation, or usually at the onset of the post-transplantation diuresis in the patients with a delayed graft function. So, urinary leak may be it could be the vesicle or the urethral, and the causes are it occurs because of the failure, either because of the failure of the uretrovesical anastomosis or because of the distal ureteric ischemia.
Dr. Usma, Dr. Usma, do we have any orientation how the patient of urine leak presents in the renal transplant?
Post-operative collection.
Yes, so it is one of the presentation the patient has post-operative some sort of collection. How it can also present?
Increase output in drain.
Yes, increase output in drain.
A post-operative collection, increase output in drain, along with patient can also manifest signs like abdominal distension.
Yes. What else there would be? Yes, decrease output from the Follies. What else it would be? So since there is urine leak, the raising creatinine is also an indicator towards clue towards urine leak, because urine will get absorbed from there. Patient usually present with abdominal pain, some sort of distension or swelling, decreased urine output from the Foley catheter, or if it's after we have removed the Foley catheter, there is decreased urine output or increased output from the drain. And usually, what we have encountered is that mostly it is from the uretrovesical anastomotic side. Rarely it could be from the distal ureter, or even some sort. We have seen a missed laceration in the ureter or pelvis as well. There's a slight leak from there as well. Yes, Dr. Malik.
Yes, as we have discussed, a common presentation case of the urinary leak will be abdominal pain because the urine can leak into the peritoneum, resulting into the peritonitis, or because of the compression effects of the larger urinoma that we can manifest in the retroperitoneal region. Other than that, we can have the increased moon leakage, decreased urinary output, and the increasing creatinine level in the serum. So the diagnosis, first of all,
ये usually नहीं होता even with larger collection
yes, larger urinary.
when it happens.
Again, because of the if there is a urinary leak into the peritoneum, which will cause the peritonitis.
फिर पेन होगा, इसका मतलब है कि पेरिटोनियल कम्युनिकेशन है, फिर पेन होगा, इंट्रापेरिटोनियल इरिटेशन व्हिच कॉजेस पेन, एक्स्ट्रा पेरिटोनियली अगर है तो फिर पेन अमूमन नहीं होता पेशेंट को, मून लीकेज होती है.
So, as a part of the initial investigation, we can go for the ultrasound, which will only reveal the anechoic appearance of the clear fluid along the perigraft site. Here we can appreciate this. And the biochemical analysis of the fluid, the creatinine of the fluid that is taken from the incision site or from the drain site will be higher as compared to that of the plasma. This is a diagnostic point. And so renal scan, it is not usually done over here as a part of the urinary fistula management, but it is described in the books because it is described as a sensitive tool for the investigation of the urinary fistula. So in the middle image, we can appreciate that the contrast is here is filled up inside the bladder and the kidney tracer uptake is seen in the graft kidney laterally. So there is no contrast extravasation over there, but in the right-sided image, we can see that there is a significant contrast extravasation is seen opposite to the kidney, indicating the urinary leak.
So ultrasound, I would like to say ultrasound is called as stethoscope of urologists. So most of the complications and diagnosis and ultrasound play a key role in diagnosing them and management. And same goes for the transplant complication as well. You name any complication, and the first line investigation would be most likely ultrasound. It will not just help us to diagnose the urological complications like urine leak, collection, lymphocyte, but also vascular complications.
Then the cystogram performed in case of the bladder leak, suspicious bladder leak. Then the management.
Dr. Maniam, can we go back? So, Dr. Hamad, suppose we have a patient in which we are suspecting the urine leak. What immediate measures you would like to take if you are a resident posted in the transplant ward? Suppose patient is not catheterized and there is drain output is around 400 ml.
First, I would like to ask the police to categorize the patient. First of all, catheterize the patient so that the intravesical pressure that is released by drainage, and it may cause some decrease in the urinary leakage. After that, as Dr. Mariam said, I would like to confirm that it is urine, so I would send a fluid for biochemistry. And if
And what would you like to see in that?
I would like to see the serum creatinine, the fluid creatinine levels that would be much higher than serum creatinine levels. That would confirm that it is urine. Uh, After confirming that it is urine, and if the uh, drain output is not decreased or the urine leak is still there, I would
Actually, it's been mentioned a small urine leak may heal spontaneously, but it's quite less likely in cases of renal transplant because these patients are on immunosuppression. There is less chances of healing and spontaneous healing as well. The urine leak can be due to surgical cause where there is some sort of our anastomotic. There is our anastomosis is not between mucosa and the ureteral wall, so there might be leak from there. It will not heal on itself. But most of the time we have to do the surgical correction or in cases of urine leak, in cases of transplant.
So, as we have discussed, that urethral catheterization should be performed as soon as possible. If the urinary leak is suspected, it will not only reduce the intravesical pressure, but also it will reduce the or stop the leak altogether if it is a small leak. Then later on, we can perform the percutaneous antegrade nephrostomy. It will not only diagnose the urinary leak, but it will also control the flow of the urine. And by this, we can also perform the antegrade double J stent. So, for the small and the low volume leaks, this can be treated by the help of this conservative management, the percutaneous intervention, and the placement of the GJ stent alone. But if there are massive leaks and if the leak is secondary to the distal ureteric necrosis, then one should go for the surgical approach. And the surgical approaches are of different types depending upon the type of the leak and the viability of the ureter. For example, if there is a simple anastomotic leak, then one should go for the distal ureteric resection and the ureteral reimplantation should be done. But if the ureter is non-viable because of the inadequate blood supply, then we can go for the ureteropilostomy with the ipsilateral native ureter. And also we can perform the cystopylostomy, in which we have to mobilize the bladder up to the renal pelvis and stitch it with the help of the psoas hitch and also extend it with the help of the Bori flap.
Cystopylostomy is one of the fancy and fancy answer I would like to say, but mostly ureteric reimplant or the ureterostomy, ureteropilostomy is the answer. Practically, most of the cases, our complication is deal with these two options we have. An important point I would like to add is that while we mobilize the ureter, it is important to not to disturb the golden triangle and to mobilize the ureter along with adventitia, so that we have a good vascular supply of the ureter, because one of the cause of urine leak or ureteric stricture is inadequate blood supply of the ureter.
So here are some from the EUA guidelines, summary of the evidence. Suspect urinary leakage based on the urinary output and the creatinine level in the drain fluid with the level of evidence 3. For early and low volume urinary leaks, conservative management may be considered again mid level of the level of evidence, that is 3. Then the surgical repair should be undertaken when the conservative management fails or when the massive urinary leak occurs with the level 2B evidence, that is the high level of evidence. Recommendations: manage urinary leak by the JJ stent and the bladder catheter and or percutaneous nephrostomy tube. Perform surgical repair in cases of the failure of the conservative management with the strong ratings. Now coming towards the second complication, that is a lymphocele. Lymphocele is basically a collection of the lymph that occurs as a result of the severed or the damaged lymphatics either along the iliac vessels of the recipient or along the donor hilum. And the incidence is 1 to 26% of the cases, and it is seen to be significantly associated with the diabetes and with the patients who are taking the mTOR inhibitors, the sirolimus therapy, and those with the acute rejection. So the lymphocele chances can be prevented by minimizing the pelvic dissection, by ligating the lymphatics, and by the inhibition of the sirolimus in the early postoperative period.
Dr. Amar, what do you think if a patient has lymphocele, how it would present?
Compression of graft, like it's like a eye or like a decreased urine output.
Please take the mic.
So it will be presented like with decreased urine output, mostly due to compression effect, and will be decreased RI on the CDI graft.
Okay, you are telling one of the extreme. There must be something in the start or in the mid part.
So will be like pain, discomfort, the first presentation.
Increased drain output. Okay, it can be.
Like in the immediate.
Yes, wound leakage, swelling. So the presentation would be more or like similar to any collection or any. It could be lymph or it could be urine. But it's significant if it's on compressing the renal hilum. So that can cause one of the other major complications, that is renal artery thrombosis or renal vein thrombosis.
So presentation is with the abdominal swelling in case of the massive lymphoceles. A significant bulge can be noted over the allograft site, and the renal dysfunction again because of the larger lymphocele, because of the subsequent ureteral obstruction leading to the hydronephrosis and the progressive graft failure. And lower urinary voiding symptoms also because of the compression effects of the bladder. The patient will have the frequent micturition. Coming towards the diagnosis, so in case of the lymphocele, ultrasound will typically reveal a characteristic shape of the roundish sonolucent septated mass just medial to the graft. Here it is. It is a septated collection which is seen just along the perigraft side, and if it is an infected, then the more complex internal ecos will be there. Again, for the differential purpose, we can go for the biochemical analysis of the fluid. Under the aseptic techniques, it should be done. So the aspirated fluid will have the higher protein content, and the creatinine concentration will be similar as that of the plasma concentration in case of the lymphocele, which is kind of a diagnostic feature from the urinary leak.
So it is important while we are making bed for the grafted kidney. So there are many lymphatics or lymphatic chain on the iliac vessels. So it is better to ligate them, just not to coagulate or dithermize them. It is better to remove that chain or you just secure them with the vicryl, or so that there is minimal chances of lymph leakage from them. Lymph leakage can also be there from the grafted kidney, from the grafted hilum as well, but mostly it is due to the lymphatics that is there around the iliac chain.
Now, for the treatment purpose, small lymphoceles.
So Mariam, can you go back one slide?
Yes.
Yes, Dr. Sayat. Suppose if there is a lymphocele correction of around 100 ml, you incidentally found it on the ultrasound, routine ultrasound that we do on in our transplant ICU. Suppose there is a just collection, a radiologist reports that 100 ml collection in around the kidney, and he suspected that is lymph. Suppose he has aspirated and the analysis shows it's a lymph, what will you do?
Sir, after if the creatinine is same or it's lymph, then sir we will wait. Or if it not decreases, then we will go for the sclerosing agent. We will put in our transplant patients with lymphocyl pyridine. Or if it remains increasing, then we will go for exploration and peritoneal window.
Suppose if there is peritoneal, you read the notes and you have seen that there was peritoneal opening that was difficult to repair. Even then, you would like to instill the pyridine or sclerosing agent.
No, sir. Then no.
Then why not?
Sir, it will cause peritonitis, chemical peritonitis again.
Okay, it can cause chemical peritonitis, I can say, but it's mostly the causes adhesion obstruction, the causes adherence and in around the bowel. Okay, doctor.
Fibrosis.
Actually, the first step is the just as you said is the aspiration, but it is very likely it will reoccur. It will reaccumulate. The next step is the drain placement. You place the drain and inject the sclerosing agent that can be pyridine, tetracycline, and few other fancy name as well. If it's not dealt with with the drain placement and sclerosing agent, and then you go for the other option of peritoneal window that can be done by laparoscopy or open or whatever whatever method you are trained in. Yes, doctor.
So smaller lymphocytes and asymptomatic lymphocytes can be managed without any treatment. They will resolve spontaneously. However, the aspiration can be performed in case of the symptomatic lymphocyte, but the recurrence rate can be as high as 95%. In case of an infected or the obstructed lymphocyte, percutaneous drainage with the help of the pigtail is an option with a success rate as high as 50%. And again, as we have discussed, that if there's a recurrent and symptomatic lymphocytes, so we can instill the sclerosing agent inside the cavity, like iodine, tetracycline, or the fibrin glow. And also it has a moderate chances of the success. And but for the large and the symptomatic lymphocytes and for the refractory lymphocyte, we can go for the procedure which is named as the fenestration or the marsupialization. So it can be done via the open approach or the laparoscopic approach. In this approach, we have to make a peritoneal and oval kind of a window, a peritoneal cystrostomy of approximately 2.5 into 5 centimeter, for which the lymphocyte can be drained easily inside the peritoneal cavity from where the fluid is resolved. And there should be an interposition omental segment is there in between this peritoneal oval window. And care should be taken while doing this procedure because the ureter may be there in the wall of the lymphocyte and can get injured. And also the opening of the lymphocyte should be large enough in order to prevent the peritoneal closure, to prevent the recurrence, and to prevent the internal hernia formation.
Dr. Jaypal, do you have any idea or concept what does that peritoneal window does, how it heals, or how it is beneficial for the treatment of lymphocyte? What it actually does, making peritoneal window?
It's make the window between the peritoneum cavity with the kidney where you place this, and which of the lymphatic fluid is there in the, around the kidney, which is goes to the peritoneum, which absorb there.
Okay, that's right. So I forgot to mention one of the presentation, the lymphocyte, if it is pressing on the ureter, the kidney can be hydronephrotic as well. This is one of the presentation as well. Any collection, hematoma or lymphocyte or urine leak that is causing the compression of the ureter, there can be hydronephrosis of the graft as well.
But it can cause hypertension also. If collection is compressing on the kidney.
Yes, it can cause.
So so it has the overall recurrence rate in case of the marsupialization is 8% and the complication rate of 14% overall as compared to the open surgery. So EUA guidelines for the lymphocyte perform the percutaneous drainage placement as the first line treatment for the large and the symptomatic lymphocyte and perform the fenestration procedure when the percutaneous treatment fails. Both have the strong rating. So before proceeding towards the vascular complications, first we should have the sound knowledge of the ultrasound Doppler, because it has a key tool for the diagnosing certain complications of the vascular in the post-transplant period. And further, the RI concept should be made. So in case of the ultrasound Doppler,
Shesha, Dr. Shesh, do you have any idea what is about RI or resistive index?
So basically, we do a Doppler ultrasound of the renal artery to look at the triphasic flow inside the artery. So different measurements are taken, and it's if it's less than 0.4, then it becomes troublesome, and then we need to intervene. But if it's up to 0.5 or 0.6, then it's okay.
Dr. Idam, anyone from your team would like to comment on resistive index or Doppler ultrasound?
Actually, madam, we don't practically do this. So, a concept we can give कि जी resistance of जो parenchymal resistance है वो versus the resistance outside of the extra जो in intraparenchymal tissue versus the main supply उसकी resistance को बताता है. लेकिन ये कि since I don't do it regularly, so I'm not the best person at this point in time to probably comment about this. Rubina, Ariba.
Honestly, like we have done this very often in our lateral practice. We haven't done this very often in our lateral practice, but however, this shows how difficult the blood has the ability to reach to the organ. So this is like the play of velocities. So a peak systolic velocity is I don't know if the equation exactly this, but since it's written, it must be this. So, like, they actually derive it through the difference of velocities in the systole and the diastole. And this, broadly speaking, it shows the resistance to the flow of blood. But we often do not do it in muscular practice, so probably the radiologist may be well versed to comment on that.
Okay, we all are right to say resistive index. It's the equation peak systolic velocity minus end diastolic velocity over the peak systolic velocity. It is actually the resistance to the resistance or to the blood flow. Clinical significance is that it has a range. If it is important or it is crucial, it helps us to differentiate between the acute vascular complication, and the chronic complication. That is one of the rejection in which the resistive index is raised, in which there is RI is raised. It means there is an increased resistance to the outflow. It can be due to renal vein thrombosis or rejection. If RI is decreasing, it's less than 0.5. It means there is some sort of acute obstruction, narrowing, or problem with the inflow to the graft. Most likely, it is due to the surgical complication, and you have to on toes to manage that complication. And time is the money. As early as possible, you intervene if the RI is less than 0.5. The better is the outcome of your graft.
so as we have discussed that
और
RI
increase resistive index का भी मतलब बता दें.
Increased resistive index, it is basically due to the increased resistance to the outflow of the kidney. Most likely, it is in cases of rejection and renal vein thrombosis.
when the graft is failing.
जूनियर्स को पता होगा कि इनफ्लो और आउटफ्लो क्या है,
Inflow means
स्पेशली जिन्होंने वेस्कुलर किया ही नहीं.
तो हमने भी नहीं किया. Inflow means renal artery. Inflow means renal artery, and outflow is the renal vein.
Inflow means renal artery, outflow is renal vein, graft vein actually. Resistive index is difference between these two, low pressure in veins and high pressure in arteries, and there will be difference in their pressures will be monitored with color Doppler intakes of that ultrasound. Actually, this shows that there is problem in artery or vein of that graft. And that is the indicator that you have to go in again or not. When we have data of this transplanted patients with abnormal resistive intakes, most of the time it was actually a problem in artery or vein when grafts were explored, and it was very Extremely valuable paper when it was published.
Yes, Dr. Mariam.
So, as we have discussed, as the RIs are the extremely useful prognostic indicator in case of the post-renal transplant measurement of the graft function, in contrast to the presence of some renovascular diseases. So, as we have already discussed, that the RI of 0.6 to 0.7 is within the normal range, and RI of greater than 0.8 is elevated, and which can be appreciated in case of the increased vascular resistance, like when the graft is failing in case of the ATN or the AKI. And as the AKI progresses, it will be further increased. RI of less than 0.5 to 0.6 indicates a suspicion for the renal artery stenosis. So the perfusion.
ये पीक सिस्टोलिक वेलोसिटी माइनस एंड डायस्टोलिक वेलोसिटी, तो पीक सिस्टोलिक वेलोसिटी आपकी डिटरमाइन करेगी इनफ्लो की वेलोसिटी को ना, जहाँ से आपकी जितने प्रेशर के साथ बैड मिल रहा है। क्या हाल है, खैरियत से? तो एंड डायस्टोलिक वेलोसिटी आपकी इंटरपैराइमल रेजिस्टेंस को जो एंड ऑफ डायस्टली आपकी फ्लो आ रहा है ना, उसकी वेलोसिटी को डिटरमाइन करिए। तो अगर हम अब इस इक्वेशन को सब देख लें, तो अब हमारा रेशो आ रहा है 0.8 से ज्यादा ऐसे ही। तो रेशो आने का मतलब ये हो गया कि या तो डिनोमिनेटर बढ़ा है, पीक सिस्टोलिक या डिनोमिनेटर बड़ा है, या एंड डायस्टोलिक वेलोसिटी जो है ना, उसका डिफरेंस कम आ रही है। ठीक है, तो ये जब ये रेशियो 0.8 का मतलब हो रहा है कि आपका इंट्रा पैरेन्काइमल रेजिस्टेंस बढ़ रही है। लेकिन अगर पीक सिस्टोलिक वेलोसिटी ही कम हो जाएगी, तो आपकी वैल्यूज इनफ्लो स्टेनोसिस की तरफ जाएंगी, जो अगर आपको देखें 0.5 में दिखा रहे हैं। नेक्स्ट स्लाइड आएगी, नेक्स्ट स्लाइड आएगा। तो ये जो आ रही लेस देन 0.5 है, रीनल आर्टरी स्टेनोसिस, मतलब ये फिर सजेस्ट कर रहा है कि इतना प्रेशर जा ही नहीं रहा किडनी को, इतने प्रेशर से ब्लड मिल ही नहीं रहा इनफ्लो की तरफ से, तो दैट इज द प्रॉब्लम ऑफ
Difference is
renal artery stenosis.
And the RI should be done at all the three poles of the kidney, because the perfusion can be different in all the three poles. It can be differed.
You can go to next slide.
Now, coming towards the renal artery thrombosis, a vascular complication, it is a rare complication with a prevalence ranging from 0.5 to 3.5%, and most often occurs within the first 2 to 3 days after the transplantation. The causes are the technical error during the anastomosis, the atherosclerotic vessels, thrombotic, the recipients if the patient have the thrombotic tendencies, and the intimal rupture during the kidney harvesting, because while doing the nephrectomy, there will be the endothelial damage, the perfusion injury to the endothelium occur, which will lead to the thrombus formation.
So I would like to add just a few points regarding the renal artery thrombosis. It can be factors can be related to while we are doing donor nephrectomy, or it can be related to recipient as well. So it is important I would like to say that the transplant surgery begins from the surgery of donor. If we are not doing the donor nephrectomy right, then there is more chance of complication in the recipient as well. So it is important to gently handle the kidney when we are dissecting the renal hilum, artery, and vein. So there is, if we are forcefully pulling that kidney, or our tissue handling is not right, or we are continuously holding the renal artery or vessels with our DeBakey or other forceps, so there is a more chance of intimal injury, arterial dissection, or these sort of complications. And the one of the other cause not mentioned here is the hypotension. So it is important to maintain good blood pressure while doing the renal transplant. Patient should be well hydrated, and there should be no acute hypotensive phase while doing the recipient or the donor surgery. In these cases, there is a more chance of that renal artery thrombosis.
So the diagnosis can be done when there is a sudden cessation of the urinary flow occur without any discomfort. If the patient is having the renal transplant recently and has had a good urine output before and presented to you with a sudden anuric phase, then you should keep in mind the diagnosis of the renal artery thrombosis. We'll do the immediate Doppler ultrasound, and it will reveal no blood flow to the allograft. And also we can do the serum creatinine level, which will be elevated in this scenario.
Dr. Adnan, suppose or radiologist, and suppose you are posted in the transplant ICU and patient was making good urine output first post-operative day. Immediately you noted that there is staff called you that output has been decreased, and ultimately there is no output. You call the radiologist, say he was there in 5 minutes. He said there is probably renal artery thrombosis. Would you like to confirm that with CT angiography or no?
Yes, sir. We will confirm on the angiography.
Okay, anyone else would, Dr. Bakar? What do you think if there is no urine output from around 1 hour and on Doppler there is renal artery thrombosis? Would you like to confirm that with the CT NG or anything?
Sir, I think so. We are increasing its ischemic time if we investigate further for if the Doppler CRI is if there is no blood flow on Doppler, then we should go to explore the.
Dr. Noman, would you like to add on?
So RA is enough for us and decrease clinical parameter, creatinine is raising and urine, there is no urine output. I would like to explore.
Okay, just 2 to 3 points. If there is any urological complication like urine leak, lymphocyte collection, hematoma, you have ample time. You can buy time, you can waste time. If there is vascular complication like renal artery thrombosis, renal vein thrombosis, renal artery stenosis, or some sort of kink in the artery, and your clinical picture is correlating with the Doppler finding, then there is no urgent or no immediate need to go for CT angio as well, because as if you delay your exploration, if you delay your correction of these complications, poor is the outcome of the graft. It's just a matter of few minutes if you diagnose it early and manage it. Even then, acute kidney injury is there. There is output can be decreased, the creatinine can be raised. There may be a complication of delayed graft function, but there is a chance of graft survival. But if you delay these complications by doing CT angio and some other delaying the exploration, then there is highly likely that you have to lose that graft.
Now, the coming towards the management. So, with the renal artery thrombosis, we have to early go for the surgical exploration, and in order to evaluate the status of the graft. Really, the graft appears salvageable. Most of the times, the graft is not salvageable, and we have to go for the allograft nephrectomy straight away. And in this situation, like if the graft is salvageable on exploration, then the iliac artery is clamped, and an arteriotomy versus a dissection of the vascular anastomosis must be performed in order to remove the clot, and then the graft can be flushed in situ and revascularized. Also, post-procedure, the recipients who are at high risk of getting the renal artery thrombosis in the future, they should be anticoagulated. So, EUA guidelines for the renal artery thrombosis. The diagnosis of the renal artery thrombosis depends on the echo-color Doppler followed by the surgical exploration to assess the status of the graft, and thrombectomy in case of a viable graft and the allograft nephrectomy in case of a non-viable ones. They are the treatment options for the renal artery thrombosis with the level 2B evidence. And perform ultrasound color Doppler in case of the suspected graft thrombosis, perform surgical exploration in case of the ultrasound finding of the poor graft perfusion, and performed an allograft nephrectomy in case of a non-viable graft with the strong ratings. But perform a surgical thrombectomy in case of a salvageable graft if arterial thrombosis is confirmed intraoperatively with a weak rating.
I would like to give a concept of in situ perfusion, and another one is in which we take the graft back to the bench dissection. In some cases, we have to disrupt both arterial anastomosis, venous anastomosis, and the uretrovesical anastomosis, and we take that graft back to the bench dissection, in which we reperfuse, remove any visible thrombus, and reperfuse them. Another concept is in situ perfusion. In situ perfusion, we don't disrupt the uretrovesical anastomosis. We usually don't disrupt the venous anastomosis. We just apply a vascular clamp again to the common iliac vessels, artery and vein. We make a small nick in the renal vein, or it can be made on the common iliac vein as well, so that there is opening for the outflow, and you disrupt that arterial anastomosis that is between graft artery and the common iliac artery where you have anastomosis. You open that anastomosis and perfuse custodial or whatever perfusion fluid you have, from that graft artery. For outflow of that perfusion fluid, you have made a small stab or nick in the graft vein from where that perfusion fluid will be out. The benefit of in situ perfusion is that your ischemia time is decreased because you have already made a venous anastomosis. So there is a hope that there is a less ischemic insult to the kidney.
Next vascular complication is the renal vein thrombosis. It is again an early complication which can be encountered in the first month post transplantation, and it has a great potential for the graft loss with a prevalence of 0.5 to 4% of the cases. And the causes are again the technical complications while handling of the renal vein. The thrombosis may occur when the donor renal vein is narrowed by the repair of an injury because of the kinking of the renal vein, the position of the renal vein due to the difficult angulation of it or the anastomotic stricture, venous compression by the larger lymphocyte or the hematoma, hypercoagulable state if the patient is having some autoimmune diseases, and the perioperative hemodynamic status of the patient really matters, because if the patient presented to you already in hypertension and severe dehydration, then it will lead to the stasis of the blood and ultimately the thrombus formation.
Dr. Shumaila, do you have any concept how the patient with renal vein thrombosis will present?
Increase RI on color Doppler.
I'm asking about clinical picture. Okay, that's you are right. It can present with an increased RI, but what patient will say on or what finding you will observe on patient?
So patient will have decreased urine output.
Okay, that's right. I would like to say any complications of any complication of the transplant present with the decreased urine output.
Sorry, sir.
I mean any complication, renal artery thrombosis, renal vein thrombosis, urine leak, lymphocyte compressing the ureter, or almost all of the complications regarding the transplant, they present with a decreased urine output. That is one of the marker that something is going wrong.
Yes, sir. Decreased urine output, rising creatinine, and patient may complain about the pain.
Yes, that is main differentiating point between the renal vein thrombosis and the other complications. In the renal vein thrombosis, patient may have tender graft. He will complain of abdominal pain, severe abdominal pain.
So there are certain risk factors. The right-sided donor kidney, because of the right-sided renal vein is short, and because of the short length, it is more prone to get compressed in the early post-operative period because of the any underlying ischemic damage. Prolonged ischemia time, because prolonged ischemia time could potentiate the thrombogenicity of the endothelium, or the resulting ATN will lead to the graft edema and the subsequent decreased perfusion and the thrombus formation ultimately. Then older donors and the older recipients will have the atherosclerosed vessels, hypercoagulable states, and the hypertension, as we have already discussed in the causes. Presentation is like pain and the tenderness over the graft, which is the main presenting feature, swelling of the graft, hematuria, and the decreased urine output. Again, the ultrasound should be done as a baseline, and it will show the characteristic absence of the venous flow in the allograft, the absence of the flow in the renal vein, and there will be the abnormal arterial signal, that is a plateau-like reversal diastolic flow is noted in the renal artery, and the kidney will be enlarged again because of the stasis of the blood, because of the venous congestion. The kidney will swell up and becomes enlarged. Management. So immediate surgical exploration and evaluation of the status of the graft should be done, despite the fact that majority of the grafts will be non-salvageable at the time of the presentation. So if on exploration the graft is salvageable, then we can go for the venotomy, and immediate surgical thrombectomy should be performed, and after clamping the iliac vein, it should all be done. And in some cases, we can also perform the revision of the venous anastomosis. Catheter-directed thrombolytic therapy can be done, but the success rate are not much higher in case of the thrombolysis. But if the graft is non-salvageable on exploration, then one should go for the allograft nephrectomy. These are the EUA guidelines for the renal vein thrombosis. The diagnosis of the renal vein thrombosis depends on the color Doppler ultrasound, followed by the surgical exploration. thrombectomy in case of the viable graft, and allograft nephrectomy in case of the non-viable graft with the level 2B evidence, and perform the ultrasound Doppler in case of the graft thrombosis with the surgical exploration in case of the ultrasound finding of the poor graft perfusion, and do not routinely use the pharmacological prophylaxis to prevent the transplant renal vein thrombosis with a strong rating. But surgical exploration in case of the ultrasound finding of the poor graft perfusion has a weak rating. And if the venous thrombosis is confirmed, intraoperatively perform a surgical thrombectomy in cases of the salvageable graft with a weak rating. Then comes the bleeding or the hematoma. Bleeding can also occur in the early post-operative period, and it can complicate the outcomes of the renal transplant. It usually manifests or evident within the first 24 to 48 hours after the renal transplantation, and it can be diagnosed by decreasing hematocrit levels, swelling over the graft site. A significant bulge can be seen over the graft site with the blood seepage from the incision site. And it is more common in those with the calcified iliac vessels who receive the higher doses of the heparin as a prophylactic anticoagulation, and in patients who are taking the anticoagulants for the other medical problems. So the bleeding can be prevented by stopping the aspirin, and if the patient is taking some sort of the anticoagulant medications in the preoperative period, so all should be stopped whenever the possible. And also during the surgery, meticulous preparation of the allograft should be done, and by securing the hemostasis throughout the dissection is necessary in order to prevent this complication. So early postoperative bleeding can occur from the small vessels in the renal hilum, which may not have been apparent before the closure because of the vasospasm. But after the surgery, when the perfusion improves, these hilar vessels can then bleed. And once the bleeding suspicion is there, then one should carefully observe the vitals of the patient, and the serial monitoring of the hematocrit should be done. And again, the baseline ultrasound should be done, which is used to confirm the diagnosis of the perirenal allograft hematoma, and the monitoring of the allograft hematoma is required. While coming towards the management, the small and the asymptomatic hematomas require no intervention, but the larger hematomas, which are requiring more than 4 units of the blood transfusion in the last 48 hours, it will require the surgical drainage and the subsequent securing the hemostasis.
So we have briefly discussed the early surgical complications of the transplant, in which we have discussed the urine leak, hematoma, renal artery thrombosis, renal vein thrombosis. Do you have any question regarding that? We have already discussed. Okay, just go on with it. Just few words regarding the immunosuppression of after the kidney transplant.
Immunosuppression after the kidney transplantation, it is the principle underlying the successful immunosuppression is the balance of the survival. So practitioners must prescribe a dosage of the drug high enough to suppress the rejection without endangering the recipient's health. And this is particularly important in the initial post-operative transplantation period in order to prevent the rejection. So the standard initial immunosuppressive regime is with the excellent efficacy and the good tolerability is here, and it consists of the three components. First of all is the CNIs, which are the calcineurin inhibitors, including the tacrolimus, commonly known as the Prograf. Alternatively, cyclosporin can also be used. The other one are the anti-metabolites, which are the MMF, the mycophenolate drugs, mycophenolate acid, enteric coated mycophenolate sodium. And the third one is the steroids, including the prednisolone or the methylprednisolone. Induction therapy. Coming towards the induction therapy should be given in those patients in which we require the sudden and the rapid sort of the immunosuppression in the first few days or the weeks after the transplantation, and in order to avoid the acute rejection. So induction therapy should be divided into the two kinds of agents, lymphocyte depleting agents and the non-lymphocyte depleting agents. The most commonly used agents that we are using over here in the lymphocyte depleting agents is the thymoglobulin, that is the ATG, and in the non-lymphocyte depleting agent is the basiliximab. ATG is used to be given in those patients who are the high-risk individuals, those recipients who are already sensitized with the antigens, or in those patients who have the DSA positive. The DSA is basically the donor-specific antibodies. So in these patients, the ATG should be administered, whereas the basiliximab, it is commonly used in low to moderate immunologic risk transplant recipients, like in those who do not have the DSA positive. Maintenance suppression. So it consists of the triple drug therapy, as we have already discussed, the CNIs, antimetabolites, and the steroids. So the CNIs, both the tacrolimus and the cyclosporin can be chosen, or the vice versa is based on the potential adverse effect of either of these agents. Tacrolimus is the preferred agent for the women and the pediatric patients due to the cosmetic side effects of the cyclosporin, such as the hirsutism or the hypertrichosis, that is the excessive hair growth, and the gingival hyperplasia. Cyclosporin is less diabetogenic as compared to the tacrolimus, so that's why it should be given in those patients who are at high risk of developing the diabetes in their post-operative period, like those who have the strong family history of the diabetes. TAC-treated patients with the tremors or the hair loss can be switched over to the cyclosporin, and same is applicable to the cyclosporin. If the patient is facing the adverse side effects with the cyclosporin use, so we can switch over it to the tacrolimus. But the concurrent administration of both the drugs is not necessary and may increase the risk of the nephrotoxicity. Patient's drug level should be monitored closely after switching. Adjunctive management, the anti-metabolite, that is the MMF. MMF is basically a prodrug. It is converted or hydrolyzed into its active form, that is the MPA derivative. It is the most commonly used adjunctive agent. And other drugs which can be used as the adjunctive agent, these are the mTOR inhibitors, which are the sirolimus or the everolimus or the azathioprine. As I safe in pregnancy, whereas the MPA derivatives, they should be discontinued with the anticipation of the pregnancy. And mTOR inhibitors are also contraindicated in case of the pregnancy, and they are beneficial in those patients who are having some sort of potential risk factors for some cancers, like particularly skin cancer, renal cell cancer, or the Kaposi sarcoma, or those who are having the possibility of the post-transplant lymphoproliferative disorder. But it is not recommended in the early post-operative period due to the ATN. These are
Okay, I think we wrap up our session. So our main concern was regarding the surgical complications that we discussed thoroughly, and these are few of the tips and tricks regarding the immunosuppression. It's basically induction and the maintenance therapy with a growing time. The dose of immunosuppression is decreased. The mTOR inhibitors are used in those cases in which we are suspecting or having the malignancy like Kaposi sarcoma or the skin malignancy or RCC.
Thank you.